Good afternoon. We would like to thank the Society for this opportunity to present our research. These are our disclosures. Obesity is a growing and serious problem in the adult US population, with about 36.5% of the population meeting obesity diagnosis criteria between 2011 and 2014. Importantly, obesity is a well-known risk factor for end-stage renal disease. Despite this, obese patients are 13% less likely to initiate peritoneal dialysis when compared to patients with normal BMI. And this is likely due to narrow treatment options offered to this patient population. Obesity has been considered as a relative contraindication to peritoneal dialysis, and this was mostly due to the belief that obese individuals suffer from inadequate solute clearance, increased risk for infectious complications, and mortality. Many of these assumptions have been challenged in the recent years. Another reason for this belief is that obese patients suffer early PD technique failure. However, research is lacking in the area of PD longevity in the obese population, especially with the recent improvements in insertion techniques, such as advanced laparoscopy with the use of rectus sheath tunnel and omentopexy. I would like to briefly describe the advanced laparoscopic technique of PD catheter insertion. Rectus sheath tunnel is a way of directing the catheter towards the pelvis and preventing catheter tip migration. The sheath and the dilator are inserted through the anterior rectus sheath and tunneled in the preperitoneal space for about 4 to 6 centimeters towards the pubis. The peritoneum is then entered and the catheter is fed through the sheath into the pelvis. And then omentopexy is performed selectively when the omentum is noted to be bulky and extending into the pelvis to prevent catheter obstruction and wrapping. The dependent portion of the omentum is brought up to the subxiphoid area and it's anchored to the upper abdominal wall with a suture. Our previous published findings show that advanced laparoscopy greatly reduces mechanical catheter dysfunction rates, need for catheter revision, and removal when compared to open and basic laparoscopic insertion techniques. Dysfunction-free and overall PD catheter survival are also significantly improved after advanced laparoscopic insertion when compared to open and basic laparoscopy. And this has not been looked at in terms of obesity. And so our study hypothesis is as follows. Obesity does not worsen PD catheter dysfunction rates, catheter survival, or perioperative complications, regardless of the operative technique used. Our study is a retrospective review of 235 consecutive PD catheter insertion operations at 4 hospitals of the North Shore University Health System performed between 2004 and 2014. We collected a variety of pre- and post-operative variables, including patient characteristics, operative and post-operative data with the focus on PD catheter dysfunction. We divided our study population into cohorts based on the operative technique used and BMI. Insertion techniques included open, utilizing a mini laparotomy incision, basic laparoscopy, where laparoscopy was used to visualize the catheter placement in the pelvis, including adhesiolysis when performed, and then advanced laparoscopy utilizing rectus sheath tunnel, selective omentopexy, and selective adhesiolysis. BMI cohorts were established using the World Health Organization guidelines. Patients included had to have evidence of post-insertion catheter use and adequate post-operative follow-up, and underweight patients were excluded from the analysis. The total patients included were 231. Our primary endpoints were catheter dysfunction, defined as need for reversionary surgery or catheter removal due to mechanical dysfunction, as well as PD catheter survival. Our secondary endpoints included perioperative complications. And a standard statistical analysis was used, including Kaplan-Meier and Cox proportional hazards models to determine catheter survival. We observed no statistical differences in age, gender, length of follow-up, prior abdominal surgeries, operation type, or ASA class between the BMI cohorts. In this analysis, we found that in the advanced laparoscopic cohort, selective omentopexy was used at a significantly higher percentage of obese individuals when compared to normal weight and overweight patients, which is not surprising given the generally increased intra-abdominal adiposity of this population. Looking at the entire cohort, there were no statistically significant differences in intra and postoperative complications among the BMI groups. And this includes infectious complications such as exit site infections, early peritonitis within 2 weeks of operation, and late peritonitis more than 2 weeks post-op. No significant differences were noted among these same variables when looking specifically at the advanced laparoscopic technique cohort. Looking at the entire cohort again, there was no statistically significant differences in the mechanical PD catheter dysfunction among the 3 BMI cohorts, and this included inflow and outflow obstruction, catheter migration, and pericatheter leak. Similarly, there were no significant differences among the BMI categories in PD catheter revision and removal rates. And this was also true when we specifically looked at removals due to mechanical dysfunction, as well as removals due to mechanical dysfunction and infectious complications. No significant differences were noted among these same variables when looking specifically at the advanced laparoscopic technique cohort. Dysfunction-free catheter survival, which takes into consideration only revisions or removals related to mechanical catheter dysfunction, is similar among the 3 BMI cohorts where all patients are considered. This is also true when looking specifically at the advanced laparoscopic technique group, basic laparoscopic technique group, and the open technique cohort. Interestingly, we observed a trend towards a higher 2-year dysfunction-free catheter survival in the obese cohort using advanced laparoscopy compared to open, with 91% versus 66% catheter survival. However, this did not achieve statistical significance. As I mentioned before, obesity is believed to be a risk factor for infectious complications in patients on peritoneal dialysis, but the literature on this topic is very conflicting. Therefore, we took our data a step further and looked at the dysfunction and infection-free peritoneal dialysis catheter survival. This takes into consideration loss of the catheter related to not only mechanical dysfunction, but also infectious complications such as peritonitis and exit site infections. And in fact, there were no significant differences in this measure between the 3 BMI categories. So in conclusion, PD catheter function and survival are not adversely affected by obesity, regardless of the operative technique used. PD catheter infectious complications are not increased by obesity, and obesity should not be a deterrent to initiation of peritoneal dialysis, as it confers similar technique success to normal and overweight individuals. Thank you.